Hello, everyone. In this presentation, we'll be discussing the role of allogeneic stem cell transplant in classical Hodgkin lymphoma. I'm John Kuruvilla from the Princess Margaret Cancer Centre in Toronto. Here are my disclosures. So it's important, I think, by way of introduction, to look at our gold standard very quickly in the setting of relapsed and refractory disease, which is autologous stem cell transplant. And this was defined by a randomized controlled trial. There are actually two, but this is the larger one, and that needs to be taken with a grain of salt because, as you can see, only about 120 patients were randomized in this small clinical trial. And so the primary endpoint here was freedom from treatment failure, something very similar to PFS. And clearly shows benefit for transplantation over standard dose salvage with Dexabeam. The numbers start to break down when you look at stratification by early or late relapse, but this was curative therapy that was maintained over several years, and thus autologous transplant became the gold standard. The only other randomized data we have in this setting that's been published is the Athera study, which looked at maintenance brentuximab post-autologous transplant in high-risk patients. And at the initial time of presentation, there was a median follow-up of 30 months, but now we have 5-year data that continues to show consistency of the primary endpoint of progression-free survival being maintained even at 5 years. At the 2-year time point, there was a 12% benefit. The toxicity was manageable. Again, it was peripheral neuropathy and neutropenia being the big issue, but no overall survival advantage in this study. Admittedly, patients went on to cross over in a good proportion, 84% of those patients in the control arm. So it becomes difficult to really understand overall survival. But the important thing here, maintain PFS at 5 years, which we've seen with the longer-term follow-up, highlights the curative potential of this regimen. And I think there's little doubt that this does improve cure. So unfortunately, the overall survival being lacking doesn't really get at that point because there are other therapies, whether it's BV or checkpoint inhibitors, that people can use. Here's some historic data that I want to give you a sense of what people used to think about how we treat relapsed refractory classical Hodgkin's lymphoma once you get into the palliative setting. And this is with conventional therapies, radiation, etc. And unfortunately, it's old data now, but a very large series of over 750 patients that showed that the outcomes generally were not good. The median PFS about 1.3 years, median overall survival about 2.5 years. And this was a setting where for a lot of people, drug development might have been thought of, but this was also a place where you could think of allogeneic stem cell transplant. So when do we think about allogeneic stem cell transplant in the modern era? So do we think about it for patients with disease progression post-stem cell transplant? Yeah, that's a reasonable place to think about it. Do we think about it for patients with high-risk features in the second-line setting? And that might be patients that are primary refractory to an anthracycline-containing regimen, or patients with a poor response to salvage therapy. And I'd say, I don't think we need to think about those patients in quite the same way anymore because of what we know about novel agents such as BV and pembrolizumab and nivolumab. You're very likely to be able to get a primary refractory patient or a patient that doesn't respond to a conventional regimen second line. You'll be pretty likely to be able to get them into a good remission and take them to an autograft. And you can also take the high-risk patient and consolidate them with BV based on the Athera data. And as you can see from those data that I showed you earlier, they tend to do fairly well in that setting, even if they have high-risk disease. So I think the main place to think about allogeneic transplant, if you have access to these therapies, will be in patients that have experienced disease progression post-transplant. Now, I'm just going to give you a little bit of the history around why we do transplants in relapsed refractory classical Hodgkin's lymphoma, because before the advent of reduced intensity transplantation in the early 2000s, this was something that people did not believe too much in with myeloablative allografting, particularly because there was a lack of data that looked at graft versus tumor effect in this disease. And we know the biology of classical Hodgkin's lymphoma is very different than that of DLBCL or indolent lymphoma. So these are 4 series published by 4 different groups that highlight the potential for response to DLI. And this was associated with a lower rate of relapse as well as response and a lower rate of chronic graft versus host disease. The challenge of interpretation of some of these is that some of these patients might have received chemotherapy along with the DLI. And so that's the challenge. And looking to the right of this table, graft versus host disease and also non-relapse mortality can certainly be an issue in these patients, reminding us of the challenge of doing allogeneic transplant successfully. So Anna Sereda and the EBMT went on to run a prospective phase 2 study called the HDR Allo trial. And I think this is probably the most important conclusion from that trial. In the 50 patients that were chemosensitive, they tended to do much more favorably from an overall survival perspective as well as from a PFS perspective. But patients that were resistant did not really appear to benefit as much from a transplant. And this is probably the group of patients to avoid taking forward to an allogeneic transplant. So here's a more recent EBMT review that to me really gets at the feasibility of doing this in the modern era. And so whether it's from a haploidentical donor source, a sibling transplant, or a matched unrelated donor, what you can tell from these data are that the one-year non-relapse mortality are reasonable, but it is in that 15 to 20% range. 2-year progression rates of about 40%, 2-year overall survival of around 65 to 70%, but that 2-year PFS of about 40% seems to be what people were able to typically accomplish in this setting. And when you looked at a composite endpoint that might include extensive graft versus host disease and relapse-free survival, so the CGRFS, this might have favored haploidentical transplants. And so in this setting, multiple donor sources possible, non-myeloablative regimens showed these favorable outcomes. Again, sensitive disease preferred. I think these were the conclusions from this setting as we got into the checkpoint inhibitor era. What really changed was in 2014, the phase 1 data that were presented with nivolumab, and again, at the very soon thereafter, the data with pembrolizumab. Again, both studies changing the face of relapsed refractory classical Hodgkin's lymphoma. So the next question became, what happened to allogeneic transplanted patients after exposure to a checkpoint inhibitor? And with the effect that checkpoint inhibitors could affect the immune system, is there the potential for higher grade toxicity that you might see with these patients? And so again, Reid Merriman put together a series here, over 200 patients, appropriate age. The majority had a favorable comorbidity index, the higher proportion of patients having received nivolumab. The disease status at the transplant, I think, is the important thing to put out here. So about 60% in CR, about 30% in PR. The number of haplotransplants here more common, but again, matched unrelated donors still above matched siblings. So again, reflecting what generally happens in transplantation today, and 60% being reduced intensity, 34% being non-myeloablative fully. When you look at the toxicity first, acute graft versus host disease might be a little higher in general than what we're used to seeing at just over half the patients, 15% being grade 3 or 4, and 2-year graft versus host disease might be kind of what we tend to see in this setting. But when you look at the outcomes on the right, the non-relapse mortality and relapse rates look very favorable. So that relapse rate of 18% appears to be lower than historical data. And the GRFS, as you can see, 47%, PFS 69%, looking very favorable here and suggesting potential benefit. But how much of this is being just driven by the fact that patients are in complete remission? We also put together a series specifically looking at pembrolizumab for the patients that have been treated on clinical trials, and this includes some patients with primary mediastinal large B-cell lymphoma as well. And again, what you can see is that acute graft versus host disease, fairly similar at around 50%, that chronic graft versus host disease rate about a third as well, and favorable progression-free survival post-transplant, acceptable non-relapse mortality and relapse rates, and again, favorable overall survival. Again, in this setting, remission in about 44% of the patients. So driving this point home, certainly these appear safe, slightly higher rates of acute graft versus host disease, and potentially favorable outcomes post-transplant. So very interesting, and perhaps reflecting a shift in how we may think of the use of transplantation in this setting. So these are data that Miguel Perales has presented on behalf of the EBMT. We're hoping to see a manuscript out shortly. I understand it's in review. and I thank Miguel for providing these slides to me. We'll just look at the outcome of allogeneic transplant based on a joint CIBMTR and EBMT analysis in the next few minutes. So the aims here were to look at adult patients with Hodgkin's undergoing allo with or without prior checkpoint inhibitor, and this was done over a period between 2008 and 2019. Any donor, any graft versus host disease prophylaxis, I think typically employed, and myeloablative or reduced intensity conditioning. So here are the patient characteristics. Nothing stands out here, though there are some differences between the groups which would need to be balanced for an analysis in terms of what was being used. Now, firstly, looking at some of the key questions here, prior checkpoint inhibitor improves PFS, as you can see with the curve on the left, hazard ratio 0.75, but does not appear to show a difference in terms of overall survival. Prior checkpoint inhibitor is associated with a lower risk of relapse and similar non-relapse mortality. So at least in terms of the ultimate toxicity, death without relapse, we don't see a worrisome signal here, and the relapse rate does appear to be substantially better with the hazard ratio of 0.53. When you put this into multivariate analysis, the significant differences that really stand out here, the PFS is statistically different, the relapse incidence is statistically different, and when you look at acute graft versus host disease, though not statistically different, that p-value is 0.09, it looks like that is the other thing that appears to be the bigger issue here. For grade 3-4, but with grade 2-4, it does become statistically significant with that p-value of 0.02. Looking at additional factors in terms of overall survival in this multivariate model, what you can see here, age is an important predictor, female sex, PR versus refractory disease, higher risk of failure, the myeloablative conditioning, higher risk of failure, poor KPS, higher risk of failure. And when you look at haploidentical recipients, they had improved progression-free survival and a lower rate of relapse, but this ultimately did not affect overall survival. So that in part could be a numbers game in the analysis. When you look at cause of deaths in these pie charts here, you can see the big difference is the lower rate of relapse in the patients that receive checkpoint inhibitors on the left, versus on the right with that sort of teal blue there. So what can we conclude in terms of understanding the differences here? There are some conclusions that come with some caveats. So the outcomes do appear favorable in terms of overall survival, though not maybe statistically significant, progression-free survival, certainly lower rates of relapse, non-relapse mortality appears to be similar, higher rates of grade 2-4 graft versus host disease. That signal with grade 3 or 4 did not ultimately be statistically significant. Post-transplant cyclophosphamide may be associated with some of the best outcomes when looking at some of the other data. That may play in with the haploidentical question there. Typically, it's been recommended that there should be some delay from PD-1 exposure, usually around 3 months when thinking about that from a safety standpoint. But again, there are many unanswered questions here as to what is happening with the checkpoint inhibitor. Is this doing something to the biology of the disease or to the biology of the patient before those cells are being infused from a donor? Is it the fact that more of these patients may be in a better response and that's what ultimately drives the outcome? Or is it some of the technical factors of the transplant now that we're on non-myeloablative, that we're no longer doing myeloablative transplants? Is it the haploidentical donor? Is it post-transplant cyclophosphamide? These are some of the interesting things that we still need to think about when understanding this. So the challenges for clinicians, unfortunately, is that we don't have level 1 evidence to guide decision making. And I think the key clinical question is, should a patient go on to receive a checkpoint inhibitor or go on to allo if in remission? And I think looking at the data, if patients achieve a CR to a checkpoint inhibitor, certainly given longer follow-up of those patients, they appear to do very well and have a low risk of toxicity. And I think that's a very easy group to say, staying with the checkpoint inhibitor is the right answer. For the patients that are maybe in a PR, the PFS still is excellent. It's over a year and it's very low toxicity. And generally in my practice, that would be, I think, a preference to stay on drug as opposed to go directly to a transplant in that setting. But that's a more challenging conversation to have with a patient. Looking at it from the side of the transplant, the factors to think about, the patient, it's, what's their age, what's their comorbidity, what does the donor look like, what is the local experience in terms of doing transplant in this setting, in the lymphoma history, what was the response to a checkpoint inhibitor, what have other drugs been used, what other options may be available, are there maybe good clinical trials available. The discussion with the patient clearly has to get into the discussion of risks and toxicity, whether they're both acute and the delayed toxicities you may experience with graft versus host disease, and what sort of treatments that may be available for relapse post-allo or at the time of progression if they're continuing on the checkpoint inhibitor and not going on to the allo. So ultimately, this does lead to very individualized decision-making and sometimes more complicated discussions with a patient as needed. So ASH 5 years ago put out these recommendations for patients receiving checkpoint inhibitors in blood. And so I will draw this to your attention. So this does make the idea that early referral to a transplant center should be considered to at least have the conversation so that people can understand, and that allo can be considered for patients in this setting in theory. When looking at the transplant strategy, they recommend at least six weeks of hold before the allo transplant. So again, a little less conservative than what had previously been thought from many experts of about 3 months, now that we understand the safety a bit better. The use of VOD prophylaxis, such as ursodiol, could be used. Again, this was a consensus and not evidence-based. We don't tend to see that signal now with increasing data that's been available now. You can think about the typical strategies we use to reduce the risk of graft versus host disease and have very close monitoring early given the potential for acute graft versus host disease. So think about very quickly initiating therapy with corticosteroids if they develop fever. So beware of other causes, not just graft versus host disease, but rapidly initiate treatment for GVHD if you see it, to try and get ahead of this quickly. And again, we know the rates of grade 3 or 4 may not be statistically significantly different, but this is the main risk we want to watch out for. Patient-specific risks, again, think about their history, think about the timing for relapse post-transplant. You have to think about how you're going to approach other strategies if they ultimately progress and need checkpoint inhibitors afterwards. So you may want to start at a lower dose. There isn't a lot of data about this in this setting. And the management of graft versus host disease, if someone's been given a PD-1 antibody post-allo, stop it, start treating with high-dose steroids again, and think about earlier intervention second line if needed. And so to summarize, the registry data demonstrate favorable results more recently. This is probably in part due to the selection of responsive patients. Whether the checkpoint inhibitor is doing something biologically different, we don't know, but this is a very important point when thinking about discussing the more favorable results these days, potentially with allo. There is no level 1 evidence still to define the role of this, probably will never be a randomized trial. We don't have other good alternatives, so there isn't CD30 directed CAR that's available, but again, drug development still remains very important. There are effective combination approaches being explored, newer drugs still being developed in this setting. So many groups such as ours try to have a number of these options available for patients that are not interested in the potential toxicities of an allogeneic transplant. This remains a very complicated discussion to have with a patient around these issues of toxicity and efficacy. And it remains very important to individualize that conversation with your patient. I think all of us as clinicians have our own biases in terms of how we think about allogeneic transplants and its potential toxicity, but there is no doubt that there may be some patients cured with allografting in this setting. And really the challenge here as a clinician is to try to find the right approach for the right patient. And that really is a challenge we always face in medicine, but particularly in Hodgkin's lymphoma, when we may have settings such as this one, where there's more than one option potentially available. So with that, I'll conclude and thank you very much for your attention.